Here. So here's another patient. Patient with long history of a stable graft, clear graft, but that got progressively worse and more difficult to fit into a contact lens.
The concern really is they have keratoconus or had keratoconus, had a penetrating keratoplasty, but the edges, the graft-host junction was getting very, very thin.
Right. And the edges, the host can still thin out over time because it's keratoconus. So since the graft is still okay, clear, hasn't gotten thinner, but the host is thinning, we're trying to replace the rest of the host.
So this looks like just that dissection now, pulling away just that tissue from the host. Down to what level? How much cornea is left beneath that cut there?
As deep as you can, and see at some point I sadly go into the eye, although not sadly, I'm expecting this. If you look at the preoperative OCT, you will see that there are some very, very thin spots on that. So with blunt dissection, go as deep as I can, use scissors to cut out one side and the other, and then make sure that as little as possible is there. Basically want a good edge on the host side. You can see how it's pretty deep and nice and clear. And on the other side, the whole host, if you look previously, is very thin. It kind of thins out. So it's not much. It's maybe just epithelium. And it almost looks like the host and the graft did one of these. So the graft migrated forward and it's just a touch at one spot. So basically replace all of this, remove this, and replace it so that it's a bigger, nicer apposition.
It seems very precarious. I mean, at some point, if this thins out so much, are we worried about the actual cornea just perforating through?
Yes. So that's the only other option would be a larger transplant, which has a high risk of rejection. The larger the transplant, the lower the risk of this happening because you're replacing pretty much all the tissue, but the higher the risk that the host will recognize this as foreign tissue. So if you have this, it's almost a barrier. Even if this rejects, the old cornea is still fine because it's inside of a protection almost. The body's like, oh, I like this tissue. But if it just attacks this one, it will leave the other graft alone. And even if this tissue becomes opacified, that's not what the patient's looking through.
A larger graft actually then puts the donor tissue closer to the limbus, to the edge of the actual cornea. That's where a lot of the immune response can happen, and that's where we can see rejection occurring.
Correct. And that's where you have a lot of the blood vessels being exposed to that tissue.
Oh, a lot of stitches going in this one.
Yes, and the sutures are very annoying because it's very loose. And there's usually with a graft, I have the host, which is fixed, and the graft, which is loose. Here I have two sides that are loose. So I have to kind of go back and forth, secure one, secure the other, go back and forth, and forth, cross until everything is secured. We sped it up a little bit and just skipped to the end because there was, I think, 52 sutures on this one.
Yep.
And they get taken out a little bit earlier because the periphery, because it's also close to the vessels, heals very quickly. So usually within 3 months, I needed to start taking out sutures. Otherwise, the blood vessel can cross the graft. Important, I can't rotate the knots that I usually do to height in the tissue. As you can see, a lot of knots exposed. So this patient has a bandaged contact lens until the knots are gone, meaning the sutures are removed.